I think there are two aspects. The first one is, of course, raising awareness of this new modality, also reassuring the patient that there has been the demonstration of non-inferiority with this new modality of administration. So it is important to educate here and inform the patient of this opportunity. Of course, it will require to assess proper reimbursement and funding aspect. And this is very different from one country to another. So I think it is important to address this at the national country level so that each center actually is well organized to be offering this strategy to their patients. To me, it's a huge step forward, and it's easy to see that this has been endorsed in other setting with other oncology drugs. I was referring to heme oncology, but also breast cancer. So we are coming after that. So we learn from this change from IV to subQ with other drug and other mechanism of action. So I think at least we're coming in a situation where it is not brand new and we can follow what has been done in the past with other drug. Thank you. It's a great question again. So I think here subQ administration has to make sense. It is not the same if your patient is receiving two drugs, one being IV, to provide a subQ administration in parallel of an IV port. Okay, so that wouldn't make sense. So to me, this is extremely important for patients that are treated with single agent or a maintenance strategy. Let's think of a patient that would have a Nivolumab plus ipilimumab first line for IMDC intermediate and poor of a metastatic clear cell RCC, then you're going into the Nivolumab maintenance, then I feel that this is exactly where you want to be using subQ. It is not as relevant where you are in the induction phase because you need to administer ipilimumab, which currently is still an IV drug. So to me, it is relevant where you are going for single agent strategy with regard to subQ use here. Another setting is the question of concomitant treatments such as TKI. So let's go for a VEGF TKI strategy. Cabozantinib plus nivolumab is an approved regimen. And so I feel here that it will be great to have real-world data capturing the safety as well in patients receiving combination with the VEGF TKIs. Now you raised the question of immunogenicity. I think in the study, two aspects were addressed. The first one is, do we see more immune adverse event? And the short answer is no. And it's especially important given that I said we have maybe even a higher exposure, so that needed to be addressed. And the answer is, despite great exposure, we don't see increased immune-related adverse events. So that is checked. To me, this has been assessed. The second one is local administration reaction. And here again, it has been addressed in the study with only grade 1, so like moderate local infusion reaction with no sequelae and not preventing further use of the agent. So to me, we address both the immune-related immunogenicity as well as the question of local site administration. Thank you. I really feel that the study is a proof of concept. It has been the same in the past with the atezolizumab study. One tumor type had to be decided to design the trial, and here is renal cell carcinoma. But it really speaks to, is this applicable to other tumor types? And to me, the short answer is yes. There is no reason for which the PK would be different or different in another tumor type or in another disease setting. I was referring to first line. Even maybe you could consider adjuvant in other tumor types such as urothelial carcinoma. And so to me, the study, because it's a PK endpoint, demonstrated the non-inferiority versus IV, and therefore is applicable, it's the concept, to other tumor setting and other tumor types. So to me, it would make sense to have a broad utilization depending or pending the approval by health authorities, both in the US as well as in Europe. So we're pending the health authorities for the use of this subQ administration, but I don't see from an oncological standpoint where it would be limited. No, I think this study is important, and this is also the reason why it has been selected at ASCO to be presented, as well as ESMO. It was concomitant publication during a previous ESMO annual meeting with Annals of Oncology publication, because this is really a practice-changing trial. And to me, it is highly relevant outside of GU oncology because it's a proof of concept.